also using it in a ferrous state, it means that there should be some means to keep it there because it is highly unstable in this state. However, that is the form that is best absorbed. This is where the introduction of antioxidants in many ion preparations become necessary. So, for example, with any ion preparation that contains the ferrous state that is best absorbed, we want to keep it there. We can add an antioxidant like ascorbic acid, like vitamin E, so that we keep the ion in the ferrous state that is best absorbed. If not, the ion would always want to become stable. Therefore, it will lose an electron and become ferric. However, the ferric state is poorly absorbed. And therefore, that is not surprising. It's not surprising at all to currently chance on prescriptions that includes iron salts with ascorbic acid. You see a lot of doctors nowadays prescribing ferric state, ferrous salt, poorly, either ferrous whatever, ferric whatever, and therefore it is not surprising. It's not surprising at all as part of to currently chance on this prescription is the main reason that to keep the iron salt unstable state with but readily absorbed form. You see a lot of doctors nowadays prescribing ferric state, ferrous salt, poorly, either ferrous whatever, ferric whatever. And therefore, all the iron that we eat from that is not surprising. The amount that we can currently into the bloodstream, that is the amount that to keep the iron salt with things, but readily absorbed. Healthy a lot of doctors nowadays prescribing taking ferrous salt without ferrous whatever, ferric whatever, and therefore all the iron that we eat that we absorb is not surprising. The amount that we currently don't have into the bloodstream, that is the malabsorption that to keep even with that iron you are likely to with things, but the remaining 90 a lot of doctors can be absorbed unless they are taking ferrous salt without this however becomes slightly and therefore all the iron that we absorb not surprising the amount that we currently sells in the blood description that is the malabsorption that to keep even with that iron you are likely to with any but the remaining 90 a lot of doctors can be absorb. Now we mentioned this general life and therefore all the iron in general that we absorb. Don't surprise the amount that currently sells in the blood description that is malabsorption that even with that iron you are likely to with any but the remaining 90 of iron we mentioned this general life and therefore all the different types of anemia, and therefore we must always remember that apart from the general manifestations, there are peculiarities, specific ones, depending on the type of anemia in question. And therefore, apart from the non-specific signs and symptoms, iron deficiency anemia may present with any of this, in addition to the non-specific ones. Of course, pale skin and mucus is one of the general ones, but issues like painless glossitis, that is when that one happens in anemia of iron deficiency. You can also have angular stomatitis, that is painful swelling and sore mouth. These two use hemoglobin and therefore reduce oxygen supply to the tongue, to the mouth, the size of your mouth, and your DIT. Why if you have reduced amount of oxygen being supplied to any tissue, remember that tissue is going to suffer necrosis, inflammation, and then you have some of these problems. Even keratinized tissues will not be spared. Tissues will not be spared, and therefore your nails, because you don't have enough iron, some of the enzymes that are involved in nail formation, they need iron to work. And therefore, the nails becomes very weak. You don't form them as you are supposed to. They begin to bend and assume a spoon shape, like the 5 nail spoonful. We call it coilomegia. That is typical of iron deficiency anemia. Then pica, unusual cravings, very common in pregnant women. Very, very common. That is a typical sign of iron deficiency anemia. A typical sign of iron deficiency anemia. Pica, you crave for unusual things like they want to eat a lot of ice blocks, they want to eat clay, even sand. It smells very nice to them. Why? Because of the lack of iron. Your brain has been programmed to search for sources of iron, and therefore sources like even starch, normal starch that we use to even iron our clothes. You want to eat it. You want to eat clay, thinking that you may get some iron from there. With a pica, that relates to increased eating of ice because of issues like the swollen tongue and sore mouth. You want to enjoy from the soothing effect of the ice block. So you turn out eating or licking a lot of ice blocks. These are all typical, specific manifestations peculiar to iron deficiency anemia. So if you see any of these, hello?
Please, I want to ask that. So these specific symptoms, what's the timeline for their development? Is it acute iron deficiency or when it's chronic? Then,
in fact, if you get acute iron deficiency, that will not even manifest as anemia. You see, red blood cells will take about 90 to 120 days. So by the time the anemia will manifest, unless it is maybe acute blood loss, if it is truly just absorption issues or lack from the food intake, it will take some time. It will take some time because the amount or the quantities that you have around that time may live for about 90 days before they die. So it is around that time that you are going to be exposed because you will not be able to have new ones replacing the ones dying. But if it is acute blood loss, that one too, the system may not even get the chance to program itself like this. And it is because that one called for urgent replacement. And therefore, the patient may not even have the time to demonstrate pica and all these things. Because for acute situations, we also do emergency management. And therefore, we solve it. Like if you have high levels of blood loss, quickly we do hemotransfusion very quick so that we solve the issue. So the body will not even have the chance to program and then exhibit some of these signs and symptoms. Please, are you okay? It is immediately corrected. Else, problem. Are you okay? So generally, acute situations may not, unless maybe the paleness, skin becoming pale, that one, you can even turn almost what we call paper white if you lose blood acutely from, say, postpartum hemorrhage or during surgery. That one, you will demonstrate it, you show it, and then quickly we have to hemotransfuse. Are you okay?
Yes, please.
All right. Okay. Any other question? All right. So note that you may have, it's not necessarily for you to demonstrate everything, but some of them, in addition to the general non-specific signs and symptoms of anemia, then that gives you an idea. Remember, these are subjective, so you can't say that that's a conclusion. No. So you need to probe further and then confirm the presence of a true iron deficiency anemia. So you have to also probe for possible underlying causes. So if you suspect any GI bleeding, that is where issues like endoscopy and those x-rays and what have you will come in to try and then confirm the source of the iron deficiency anemia. You have to also make good use of your FBC. And then if at that point it depicts a microcytic hypochromic anemia, in this, I mean your MCV will be low, your HB will be low, of course. You will have MCHC, MCH also being low, demonstrating the hypochromic nature. Microcytic means that the MCV is lower than the lower limit of normal. So we say microcytic anemia. Hypochromic, the MCHC is lower than the limit of normal. The red cells are pale. So microcytic hypochromic. Remember, it is not only iron deficiency anemia that may present with this. Remember that anemia of chronic inflammation can also present with same sideroblastic anemia and thalassemias. And therefore, as we did on slide 9, that table that we use several parameters like Menzel's index, like iron studies, history, peripheral blood smear to try and then differentiate between the 4 different types of microcytic anemias you may have to do, especially between iron deficiency and anemia of chronic inflammation. That is where we did the iron studies. And the parameters, you realize that if it is a true iron deficiency anemia, we expect serum ferritin and serum iron to be low. Of course, you just don't have. So you don't expect to have iron in the blood. Neither do you expect iron to be stored in the tissues. You don't have. Transferring to will be low. You just don't have iron. However, total iron binding capacity will be very high. Why? Because the binding surfaces on the transferrin, they are empty. And therefore, if you put iron in there, there will be high binding capacity to this iron surface. If you confirm this, then you know that you have diagnosed a true iron deficiency anemia. Signs and symptoms, FBC, and the iron studies. This will confirm a true iron deficiency. Remember, sideroblastic anemia is hiding somewhere. Anemia of chronic inflammation is also hiding. The picture on the FBC will be the same as iron deficiency. However, in those 2 scenarios, we don't lack iron, especially in sideroblastic. The patient may even have more than excess. And if you conclude without confirming with some of these labs, and straight away you throw in iron, you may cause iron overload. And iron overload can cause a lot of problems. As always, confirm the underlying cause of the anemia before you make any intervention. Now, we have confirmed iron deficiency anemia by utilizing the physical manifestations, utilizing the FBC, utilizing the iron studies. Confirmed. And therefore, we must treat by introducing iron to the patient. Before we go to that, any queries? Any queries? Any queries? Any queries? So we've diagnosed. The management is simple. We don't have iron. Let's put in iron. That is the problem. Now, if the hemoglobin concentration is not too low, maybe is around the lower limit of normal, or very close to the lower limit of normal. It is within range, but it is very close to the lower limit of normal, or it is just at the lower limit of normal, then there is the chance for the person to slip and become anemic. So if, say, for example, in adult male, we are using 13 grams per deciliter to 18 grams per deciliter, and that person is around 14, 13, especially 13, then we look at the patient condition, eating habit and everything is poor, then there is high likelihood that this patient may tip into anemia, and therefore we will have to prevent and then avoid that. So we will do prophylaxis. The patient has some risk factors that at 13 the patient can easily slip and become anemic, 12 and below. That is when we do prophylaxis. Again, in pregnancy, we have increased iron demand, fetus and then the mother. And therefore, if we don't take care, the mother alone may not be able to consume enough to meet the demand now. There is increased physiological demand. And therefore, in those situations, we can also do prophylaxis. If it happens, then we are treating. If it hasn't happened, we only do prophylaxis. Obviously, prophylactic doses will be lower than treatment doses. So we give normally 50 milligram daily, or anything between 50 to 100, below 100 milligram daily by way of prophylaxis, just to make sure that the patient doesn't tip into anemia proper, but still maintain, if not anything, at least remain at the lower limit of normal. That is the input of prophylaxis. But the moment through iron deficiency anemia is confirmed for adult males below 13, then we have to give iron in the treatment those range. How do we do it? For adults, 100 to 200 milligram elemental iron. Please listen. We are referencing it in terms of the elemental iron, not the iron salts. So the 100 to 200 milligram daily that you are seeing here is in reference with elemental iron, not the iron salt. We are not referring to 100 to 200 milligram ferrous sulfate daily, nor ferrous gluconate daily. We are talking about the actual amount of elemental iron in these salts. We need between 100 to 200 milligram daily to be able to treat iron deficiency anemia. For children, we do 3 to 6 milligram per their kilogram body weight. Again, referencing to elemental iron needs daily. Because we are having iron deficiency, it means number one, we don't have iron in the serum. Number two, we don't have iron in the tissues. We truly lack iron. So in this case, when you're treating, the target is not only to replenish what is in the blood. If you do that, the patient will finish everything and in no time bounce back to iron deficiency anemia. To avoid this, we give the treatment for about 1 month, 2 months to 6 months. Why? Because we need to load enough to replenish not only the serum loss, but also the tissue storage losses. So you give it for such a longer period. The minimum should be at least 1 month. So if somebody is being treated as iron deficiency anemia, and you've seen that they're giving the person 1 bottle of ferroglobin or 1 pack of Totima, that is funny, because the minimum should be 1 month. Other references, even they prescribe that we do 2 months to 6 months. Others don't even consider 1 month. They think 1 month is not enough. So you must do at least 2 months. But the minimum should be 1 month. So if you are doing treatment proper, Totima, every 10 days, 1 pack will get finished. Because every pack contains the 50 milligram vials, just 20. So if you have to take the lower limit of the therapeutic dose, which is 100, it means 1 BD. And within 10 days, 1 box will be over. It means the patient will have to take at least 3 boxes. So if you buy just 1 box, you are joking. Why? Because in true iron deficiency anemia, you lack both the iron in the storage sites. Your ferritin is low, your serum iron is low. And therefore, if you give it for shorter periods, you are only dealing with the one in the serum. You wouldn't have enough in the tissues. Easily, you will bounce back to square one. Hence, do it for at least 1 month to 6 months. Now, how do you get your iron? Your iron, because the drugs doesn't contain elemental iron. the drugs, we use iron salt to prepare those products. And therefore, the only thing that you need to know is to know the various iron salts available and their respective elemental iron content. I repeat, you have to know the various iron salts available, and each of them, you must also know their respective elemental iron content, such that the moment the formula states that, for example, one capsule contains 200 milligram ferrous sulfate, or one tablet contains 200 milligram ferrous sulfate. Since you know that for ferrous sulfate, the elemental iron content is, say, 33%, you only need to do your calculations and note whether the one tablet or the one capsule or the 5 ml or the 10 ml will be able to deliver the minimum of 100 milligram elemental iron for adults, or 3 milligram per kilogram body weight for pediatrics. If not, then you have to double the dose. If it is capsule, the patient may have to take multiples to meet the minimum requirement for treatment. So as for the various elemental ions and their elemental iron content, the salt and the elemental iron content, you must know. If you are lucky, the manufacturer will state the elemental iron content per a certain tablet, a certain capsule, or a certain meal. Then that one, you relate that, okay, this product, they are saying 5 mils contains 50 milligram elemental iron. Fine, then I have to let the patient take 5 mils BD, so that each 5 mil will provide 50 milligram elemental iron. And in the day, 50 plus 50 will give us the 100 milligram. That is the minimum. So you can't run away. You must note, for example, ferrous fumarate as a salt. Forget about the strength of the syrup or the tablet. You just need to know this. Then when it is stated, you do your calculations. That is if it is not presented in elemental iron form. So ferrous fumarate is 33%, I think one of the highest elemental iron content. Ferrous sulfate, we have two forms, the dried form and the hydrated form. The dry one also has an elemental iron content in terms of percentage, 33. The hydrated one, 20. So when you are talking about ferrous sulfate, you must confirm whether it is the dried one or the hydrated one, because they all don't have the same elemental iron content. Then FAC, ferric ammonium citrate, 16.5 to 18.5. Ferrous gluconate, that is tortima. The active ingredient in tortima is 12.0. But we are lucky because in tortima, they present it in terms of elemental iron content. So you will see that one vial contains 50 milligram iron, that is elemental iron. They don't present it in terms of the salt, which is ferrous gluconate. We are looking at iron 3 hydroxide or hydroxide polymaltose. The percentage content in terms of elemental iron is 28.0. So it doesn't matter. This is not as in exhausted. We have several other iron salts. All you need to know is to find their elemental iron content. In case the manufacturer will not state the elemental iron in it, but rather present it in the form of the salt. Say each 5 ml contains ferrous sulfate 200 milligram. You know that the dried one contains 33%. So you just calculate 33% of 200, and you know that approximately each 5 ml will contain 65 milligram of elemental iron. Will that be enough for treatment? No. It means that you have to double it within a day. So 5 ml BD, 65, 130, and you are within the range of 100 to 200. If you are treating, you should fall within the range. But if you are doing prophylaxis, since 5 ml will give you 65 milligram, you can use 5 ml daily for prophylaxis, but not for treatment. Remember, your target is to replenish both serum iron and tissue iron stores, and therefore the duration must be extended to at least 1 month to 6 months. Any queries? Any queries? Any queries? Class captain, are you there? Lana, I hope I got it right. Lana, are you there? You don't have any question today?
No, stay.
All right. I know you by all means ask, so I'll be waiting. All right. In certain situations, maybe the patient has some malabsorption syndrome. We may decide to dodge the GIT because the patient cannot absorb and do 100% bioavailability. That is parenteral IV administration. Unfortunately, during the olden days, you give iron by way of parenteral. Patients used to react a lot, anaphylactic reactions. But we have improved a lot. And the newer agents in the form of iron dextran, iron sucrose, iron 3, isomaltoside, and the rest, they come with minimal to no or zero anaphylactic reactions. They come with minimal. But in fact, I must tell you that slightly, parenteral iron may have slight advantage, not really clinically significant, over oral iron, except in patients with malabsorption syndrome. If not clinically, the benefit that you get from parenteral iron, it's not significantly different from the one that you get from absorptions, as in the oral one, provided the patient can have adequate absorption. Also note that, yes, before I forget, if you do this recommendation both for adults and pediatrics, your expectations is that within a week and 1 week to 2 weeks, the patient's hemoglobin concentration will increase by just 1. If you are to go by this recommendation, 100 to 200 milligram elemental iron, 3 milligram per kilogram body weight of pedics, your expectations, your target is that within a week or 2, the patient's hemoglobin concentration will increase by just 1. A whole 1 week to 2 weeks. That is to tell you that if you are in acute need to increase hemoglobin, iron administration is not an option. It can't help you. If there is an emergency and therefore the patient, for example, there is acute blood loss, hemoglobin is very low, the patient is almost dying, and then you need quick replacement, please, iron cannot help you because it takes about 1 week. Meanwhile, we need the results now, not in 1 week. And therefore, iron is not an option when there is an acute need to increase. It will take about 1 week to 2 weeks to get +1, 3 weeks to 4 weeks to get +2. Disappointing. And therefore, at that point, don't go for iron, especially thinking that the IV one can work very fast. No, you'll be disappointed. Whether the parenteral or the oral, iron takes time to give you the week before you get +1. And therefore, in acute blood loss, don't go there. Again, if you take iron preparations, especially the parenteral ones, and then you begin to build up, at that same time, it also reduces GI absorption because you did not have, and now you are providing. The body slow down further absorption from the GIT. And therefore, giving oral iron right after parenteral iron administration will not give you any benefits. You may even have reduced absorption. The moment you have reduced absorption, high levels staying in your GIT, you are going to suffer from the GI problems of either constipation or diarrhea with irritations, nausea, vomiting. Therefore, it's not necessary for you to continue IV preparations with oral ions. In fact, because of the olden days lactic problems, it is still important that even if you are dealing with the need, still try and give a test to see if the patient will react. If the patient doesn't react, you are free to give the dose that you need. Ladies and gentlemen, this is how you manage iron. You must also note that, yes, we are going to get increased hemoglobin for iron, but iron, especially if you are doing the iron with high doses, high elemental iron content. Maybe you are doing the product that will provide you 200 milligram element, you are hitting the upper limit recommended. High levels of iron are the cause of GI abnormalities. Again, constipation, nausea, vomiting. If any patient is on any type of iron preparations, the oral ones, some of these manifestations occur. You can do this. Reduce the dose so that the elemental iron that you are giving to the patient today will come down. But if you are treating, never go below 100. But the moment you fall below 100, it will no more be within the treatment range. You'll be doing prophylaxis, which won't work. So you can reduce that same iron preparation, the dose that you are giving, so that you come down to, let's say, from 200 to 150 or 120 or 100. Or you can switch to another iron preparation with a relatively lower iron content. So, for example, if the patient is on ferrous sulfate or fumarate, if you are unable to reduce the dose because of, say, the strength per capsule or tablet, then you can switch to ferrous gluconate that has 12% elemental. The target is to reduce the amount of elemental iron going to the patient, but never compromise the lower limit of 100 milligram recommended. That is if you are doing treatment. Any queries?
Yes, please. I have a question.
All right.
Yeah, please, I want to ask that if you are on the oral preparation and then maybe you notice there is malabsorption, so maybe I'm just citing, so you decide to maybe switch to the IV iron. Is there any conversion that we have to take notes of? Or
yeah, so the conversions would have been considered if there was or there is enough absorption, so that you, by way of the conversion, you maintain the same standard. In this case, you are not even absorbing, and therefore you are having lower bioavailability. And therefore, there is no way or it's not necessary to consider even your baseline, because it wasn't working. And the baseline that is not working is of no use. I hope you get it. It's of no use. And therefore, even if you have to consider it and then do any conversion calculations, it won't help you, because you don't even know the level of absorption. You just know that there is malabsorption. You go in there and it's not working. Then you realize that malabsorption. So the baseline from the oral one is of no use, and therefore you switch. Each of the parenteral ones have their own starting doses with possible adjustment. And therefore, depending on the type that you are using, you look at the literature and then do your start dose and adjust according to response. Please, are you okay?
yes, please.
All right. Any further queries? Any further queries? Yeah, hello.
You mentioned 10% of dietary iron is what is being absorbed. If you take that as a tablet form, are you expecting similar absorption rates?
Yes, in general, whether it is from diet or from, we are not likely. The access to the blood and then do the work may not even be up to 100 milligram. But the amount that you need, if you swallow 100 milligram, it's likely that you get the required amount in the blood and in the bone marrow for the work to be done. So we are saying that to be able to meet the requirement for adequate hemoglobin production, don't swallow below 100 milligrams, because obviously, since it's not an IV, you are not going to get 100% bioavailability. And we are quoting that it is what? Around 10%. 10%. You may step it up a bit when you add some antioxidants and those agents like ascorbic acid, but still you are not going to get anything far above 10%. And the moment the thing begins to correct, the 10% self you are not going to get. It will start reducing probably to below 5%. That is how the situation is. But if you are able to take the minimum of 100, even with a 10% absorption, it will be enough to help you get that 1 milligram per deciliter within a week or two. That is what they are recommending, and that is what you are likely to get. Please, are you okay? Are you okay? Hello? Are you okay with the explanation? If not, hello? Please, I'm waiting for the response before we continue. Are you okay?
Sir, please,
Yes,
can you
thank you,
go
Pam.
on the previous slide?
Yeah, so I'm
Yes,
saying
please.
that as you are not
Sir, please,
receiving IV,
I have a question.
obviously it's never. Are you the one who asked the first one, the first question?
No, please. Please, I wanted to ask. I saw intravenous iron.
No, wait. Hello? Wait, let's make sure that you are done with that question before you come in. So the one who asked the question, please, are you okay? If you are there, kindly unmute and let's hear you.
Very okay, Pam. Thank you.
All right, okay. So now please come in. The next one, the next question.
Please, I
Hello?
saw that IV iron should not be given during acute bacterial infection. I wanted to know why.
Yes, it's obvious. I remember when we were discussing or doing the introduction, we talked about inflammatory states. Infections will be one of them. And if you give iron at that time, your enemy, which is the pathogen, will utilize the iron, proliferate, and harm you. So the infection may become worse. So why do you have to harm your enemy for your enemy to kill you? You see the thing. That is why even the body itself is trying to shift bloodstream so that the invader will not find iron, utilize it, and harm the body. Hence, pushing iron to storage tissues, preventing macrophages to release iron into the bloodstream, and also minimizing iron absorption from the GIT. All these mechanisms are targeting avoiding iron presence in the blood so that the invader will not utilize the iron. So if you give iron during the time of infection, you are only providing or supplying ammunition to your enemy, and the infection may get worse. Hence, it's not advisable. This is proven for malaria and GIT infections that can lead to diarrhea. At least these two. Several others are debating on it, but at least for malaria and GI infectious diarrhea, there is a proof. And therefore, normally, some school of thought will advise that when you are giving treatment of malaria, normally, if it's uncomplicated malaria, then you are doing the orals, artemisinin-based therapies. It takes just 3 days. And therefore, you have to wait for the 3 days before you give the iron. You need the drug to clear the parasites. Then afterwards, you treat the anemia. Because the 3 days can't do anything. If you start the iron today, by 3 days, from our discussion so far, we said it will take 1 week for you to get 1 gram per deciliter hemoglobin. So if you are in a rush or you are in dire need iron or hemoglobin increase, you better go for hemotransfusion, not iron. So you have to wait. If not, you are ammunition to mafia you. Please, are you okay? In addition to the GI problems, the infectious agent utilizing the iron. Iron too can cause diarrhea, and that precipitate the infectious diarrhea. So with that, it is two things of causing diarrhea to precipitate the existing infectious one, and you providing more iron for the infectious agent to use and worsen the condition. All right. So are you okay? Can we continue?
Please, your line was breaking. Hello.
Can we continue?
You were talking about iron causing diarrhea. Your line was breaking, so I didn't really get it.
So one of the problems, in case maybe you have an infectious diarrhea and you are giving iron, is that apart from the iron being utilized by the organism to worsen the situation, iron itself on its own also has a side effect of diarrhea. And that, if it happens, it can add onto the existing one. Then you now have two problems: iron-induced diarrhea plus infectious-induced diarrhea. Then you are in trouble. So at least these two, infectious diarrhea and malaria, it has been proven. It has been proven. And of course, it is only prudent for us to extend this to several other infectious states. Just wait, do your treatment, and then, or once you realize that the bacterial load has reduced enough to a level where it is not significant, you can introduce. If you are to increase it quickly, then you go for hemotransfusion, not time, because iron itself will not help you in acute need of HB increase. No, it won't help you. Are we okay? Also note that
hello, Doc.
We have to talk about iron overload.
Hello, Doc.
Yeah, hello.
Yes, please. What about where
I can hear you.
Where the inflammation causes the level of the hepcidin to increase, which may also affect the iron absorption?
Yeah, so that will even add to the problem, because the thing that you are even going to give orally, because of hepcidin, you'll be disappointed. Absorption will be very, very low.
So
because at that point, your body has been programmed. Yes. So it again adds to the whole recommendation that it's not necessary to give iron around that time.
Yes, please.
Even if you give, absorption is going to be worse.
Yes.
All right. Okay. Thank you very much. So we will also talk about iron overload, but when we get to, I think, the next few slides that we are talking about hemotransfusion. Since we are giving iron here, there is always the tendency to cause iron overload. But I've tackled that one, I think, under the next few slides. So we will talk about iron overload. All right. So now let's look at the next in command.
Hello, sir.
Anemia of chronic disease. Yeah.
Hello, sir. Please, the lines wasn't good, so I didn't hear that.
Hello.
Hello, sir. Please, can you hear me? Hello?
Yeah, I can hear you.
Yes, please. A quick one. The lines wasn't clear, so I didn't hear that. You said you said that like when there is an infection, let's say if you have malaria, at that time it's not good to take iron because due to the infection, absorption will be impeded. Or
if the infection avidly causes inflammation, as your other colleague said, your body at that time is programmed to reduce iron absorption. That is what we are going to talk about now, anemia of inflammation. It includes that mechanism. So even at that point, if you give iron, absorption will be worse off. So you are not going to enjoy the benefit of the oral iron even unlike when you don't have any inflammation. So that one is applicable here. So you would understand it after we have discussed anemia of chronic inflammation. All right. So now, the name is anemia of chronic disease or anemia of chronic inflammation, but this excludes chronic conditions like CKD and liver disease, because the mechanism by which this anemia occurs is not the same mechanism that we get anemia from CKD and liver disease, though those two are also chronic conditions. I repeat, the name is anemia of chronic disease or anemia of inflammation. But this particular type of anemia, it excludes the anemias that we get from CKD and chronic liver disease. Why? Because the CKD and chronic liver disease anemias, they have different pathophysiology, different from what we are going to talk about, the other inflammatory or chronic conditions that we have classified under this. So don't add CKD induced and then chronic liver disease induced to this type of anemias, though those two are also anemias of chronic disease, but the mechanisms by which they cause anemia is different from the mechanisms by which the ones that we are going to discuss, they cause anemias. Noted. So what is this? This is the second in command, apart from iron deficiency anemia, and it normally occurs with inflammatory conditions. For example, arthritis. So we are talking about rheumatoid arthritis, chronic musculoskeletal conditions, gouty arthritis. What are you? Malignancies, cancers are inflammatory in nature and they are chronic. HIV is inflammatory. Even diabetes is inflammatory. Do you agree that diabetes, we have inflammation in there? Is diabetes inflammatory in nature or not? How do you justify this? Especially the both are type 1, type 2. Type 1, type 2. Are they inflammatory or not? Can you justify that diabetes is an inflammatory condition? Class captain, you and your colleagues, how do you justify? How do you explain this, that diabetes, you claim diabetes is inflammatory in how?
I would like to do.
Yes,
hello.
Go ahead. Yeah, listening.
So we know that diabetes has to do with excess sugar in the bloodstream, which is not taken into the cell. So logically, the glucose is not supposed to be in the blood for long. So in a situation where a patient is diabetic, it means that the sugar is likely to stay in the bloodstream for quite some time. And because the sugar is not supposed to be in the bloodstream for 5 minutes.
Go ahead. Just adjust yourself a bit and then continue.
Adjust yourself because and then sugar is not supposed to be.
Your line is breaking.
All right. So because sugar is not supposed to be in the bloodstream for a long time, can you hear me?
Please continue.
Yeah, so because sugar is not supposed to be in the bloodstream for a long time, in a situation where a patient is diabetic, it means that if the blood glucose is not being able to be controlled well, the body devises an inflammatory response that releases other inflammatory factors that can lead to the inflammation in diabetes.
You are very close, but I'm not getting the link very well. I've seen, yeah. Thank you, though, but I'm not getting the link. You realize in type 1, you develop antibodies against either insulin or the beta cells of the pancreas. That is inflammatory. In type 2, normally when the patient is obese, and of course, abdominal fat is very bad, and it releases a lot of inflammatory cytokines. This makes diabetes inflammatory in nature, and it is chronic. So even diabetes can do that. Several other infections are all inflammatory in nature. GIT problems like inflammatory bowel disease, Crohn's disease, ulcerative colitis, these are all inflammatory in nature, and they can contribute to anemia, with the picture being almost the same on the FBC panel, just like iron deficiency anemia. As I said, CKD and heart disease and liver disease can also cause anemia because they are chronic, but their pathway is different. For example, in CKD, the renal cortex is affected, and therefore the cells that produces erythropoietin are not doing well. You lack or you have reduced levels of erythropoietin. That leads to anemia. The anemia of inflammation doesn't have the same pattern. It's different. We are going to discuss it. I will even let the one who mentioned hepcidin to take over and then explain that. If you are looking at anemia of chronic disease, you can link it to CKD. Chronic heart disease, like anemia of heart failure, you are not perfusing very well, and other organs are going to suffer. If you have liver issues, in dying needs, when the bone marrow is unable to produce enough red blood cells, organs or tissues like the spleen and the liver, they take over and manufacture some amount. That is when the bone marrow is not functioning well. And therefore, if the liver is not functioning, you could also suffer from anemia. This pathway is different from the one we are talking about. The one we are talking about is chronic inflammatory conditions giving rise to anemia with a whole different pathway, not like what we have discussed. So when you see anemia of inflammation or anemia of chronic disease, kindly exclude CKD-induced anemia, liver disease-induced anemia, and then heart disease-induced anemia. All other causes will now be considered as part of what we are discussing.
Doc.
Now,
hello.
What we note, please, the one who mentioned hepcidin. Yes.
Hello.
The fact that you have mentioned. Yeah, hello.
Doc, please,
hello?
To take us back, but
hello?
I have a question.
Yeah, hello. Yeah.
Sorry to take us back, but I have a question on the elemental iron. With the table, you didn't give us 6 strengths of the salts.
I didn't give you.
Like, do you need specific strengths of the salts to correspond to the?
No. Once you have the percentage, what do you need the strength for? It is more difficult to keep strength in. You see the number of brands that we have. If you are talking about ferrous sulfate, you can have about 1,000 different brands with different strengths. How can you keep this in your head?
I didn't see the percentage. Sorry. Thank you.
Okay. All right. So these are the percentages. I was even mentioning some of them. So that is that. Percentage elemental iron content. So that is that. All right. So please, the one who mentioned hepcidin, I want you to take over the mechanism. But before that, let me add this. So issues like malignancies, apart from the inflammatory nature, you realize that even the drugs that we are going to use to treat you, they also have side effects of anemia. The chemotherapeutic agent. Why? Because they kill almost every cell that has a fast or high turnover rate. The selective toxicity of chemotherapeutic agents for cancer management is mainly based on the fast growing rate of cancerous cells relative to normal cells. and therefore they attack cancerous cells more than normal cells. The difference is the rate of growth. And therefore, any other normal cell with a faster turnover rate is also going to suffer. That is why if they are put on chemotherapies, they become Sakura, because hair cells also grow faster. So you get Sakura. You can get ulcer because the GIT lining, it also has a fast turnover rate. And therefore, the cancer chemotherapeutic agent will attack them. Not to forget RBCs. RBCs also have what? High turnover rate. So just like cancerous cells, just like the GIT lining, just like the hair cells, RBCs are also going to be targeted by the cytotoxic agent, and therefore you can get anemia. It is evident that most people, when they are put on anti-cancer agents, they get anemia to the extent that they can only be saved by the introduction of erythropoietin. So you have the cancer itself as a possible cause, and the drugs also contributing to the problem. Some of the drugs can even impair bone marrow. They can destroy the bone marrow itself. Apart from targeting the RBCs, they can go to the manufacturing site and blast them. That is the problem with cancer and its management. The condition itself. Yeah, hello?
Please, I can't see your screen.
I think you have to refresh. Is it the same with everybody?
No, please, sir.
No, please.
Yeah, so please, you need to refresh. All right. So for cancer, the condition itself will mafia you. The drugs that we use for the management will mafia you. Even the radiation to target fast-growing cells. So if you have to go by radiotherapy, it will also mafia you. So cancer comes with a lot of issues with anemia. Now, back to the pathophysiology. Please, the one who mentioned hepcidin, I'm sure you know the mechanism, so kindly take us through. Please mention your name first.
Okay, my name is Justice.
Sure, Justice. Let's hear from you.
Okay, so what I know is when the inflammation mediators such as the cytokines, they normally stimulate the hepcidin production in the liver. And the hepcidin serves as a gateway of iron in our body. So they normally block the release of the iron from the storage cells. They also reduce the dietary iron absorption, as we said. So basically, that's what I know.
Perfect. So now, due to the inflammation, as he said, you have the liver releasing hepcidin. We are not going to make iron available for the enemy. Hepcidin's task is to reduce serum iron through diverse mechanisms. One is, even if you swallow iron, you are not going to absorb. If iron is already in the serum, we are packing it and then we will hide it somewhere in the tissues. Iron that will be released from the reticuloendothelial system, the macrophages in the liver, the spleen, and the bone marrow, we are not going to allow them to release iron into the bloodstream. So at that point, all sources of iron that we need to come into the blood have been blocked. That is why we are saying at that time, if you swallow iron, you are going to be disappointed, because hepcidin would block iron absorption or reduce iron absorption around that time. And once iron is not available in the blood, you are not going to transport it to the bone marrow for production of hemoglobin and, for that matter, RBCs. Iron should be available in the blood for it to be transported to the bone marrow. And in this condition, it means that iron is available in the bone marrow because iron will not be available in the blood. As simple as ABCD. And therefore, the picture will be like there is no iron. Because you have iron, it's not about storing the iron in the tissue. Send the iron to the bone marrow. If you have it elsewhere in the body and you are not making it available in the bone marrow, it's almost the same as you don't have oil. and therefore you will present with microcytes with hypochromic cells. That is what the similar thing to iron deficiency anemia. In addition to this cytokine proposed mechanism, you realize that in infectious state, you produce a lot of WBCs. As we started, we said all the 3 cell lines, RBCs, WBCs, platelets, they all originate from the pluripotent stem cells, the hematopoietic stem cells. In inflammatory conditions that you are producing more and more WBCs, it will be to the disadvantage of RBC lineage as well as the platelet lineage. And therefore, you're also going to have reduced amount of RBC production. Thank you very much. Is it Jonathan or Justice? Thank you very much. Any queries? If you don't understand anything, please ask. I'll let my lawyer Justice explain. And how will these individuals present? Symptoms and symptoms as discussed earlier. And obviously, if we claim that there is a certain chronic inflammatory condition, it means that the signs and symptoms of that condition will be there. So, for example, if it's rheumatoid arthritis, we expect the patient, apart from the anemia signs and symptoms, to present with these joint issues. So, joint pain, morning stiffness that will last more than 30 minutes, swollen joints, tenderness, all those things will be there. You know that, okay, it's likely. And even if you confirm for rheumatoid arthritis, rheumatoid factor will be positive. Anticyclic citrulated peptide antibodies will be positive. You see that thing? So all these things will be there. In addition to the confirmation, then we know that, this anemia is most likely coming from the rheumatoid arthritis, which is a chronic inflammatory condition. For it is confirmed. We have confirmed that this anemia is inflammatory in nature. But remember, because of hepcidin not sending iron, or you are not having iron in the blood, if iron is not in the blood, it can be sent to the bone marrow. So it will be like you have iron in the body, and hence a similar scenario when you are doing the FBC, almost the same scenario as we have in iron deficiency. And therefore, to confirm it's not iron deficiency, but rather anemia of inflammation, to do the iron studies. To do the other day, you realize that in true iron deficiency, serum iron will be low. In this case, the serum iron will be low because we are pushing iron away from the cell. However, because we are pushing iron from the blood only to be stored as ferritin in tissues, and therefore ferritin high. In the case of iron deficiency, you just don't have. So ferritin cannot be high, it can be low. In the case of total iron binding capacity, anemia of chronic, it will be low.
Hello, sir. Hello.
Hello.
Hello,
Yeah,
sir.
hello.
Please, I love you at the iron studies.
Okay, so I'm trying to use the iron studies to differentiate between a true iron deficiency anemia and anemia of inflammation. Why? Because on the FBC, the two are going to have similar picture. The two is below, you differentiate between them. You use the iron studies. Let's start. What are the parameters? Serum iron. In iron deficiency, you don't have iron, so you can't have. In anemia of inflammation, you are pushing the iron from the iron from the blood. So that one too will be low, cancelled out. So using serum iron, cancelled. The two will have low. Ferritin, with the form in which iron is stored in the tissues. You expect iron deficiency still to be low, but you just don't have iron. But in anemia of inflammation, you have decided to push the iron from the blood into the storage site, and therefore you expect ferritin to be high in anemia of inflammation. You expect ferritin to be high. With transferrin, not anything revealing, but let's look at the total iron binding capacity. In a true iron deficiency, the binding surfaces for iron on transferring, they are all empty. You don't have iron to be binding. But in anemia of inflammation, they have occupied. You have iron that has occupied these surfaces for transport to storage site. And therefore, total iron binding capacity will be low in anemia of inflammation. And it will be very high in a true iron deficiency anemia. With this, you differentiate between the two. That is why I'm referring you to slide 9, because using the FBC, iron deficiency and anemia of inflammation cannot be separated. And therefore, you need the iron studies to separate them. However, remember that in a true... Yeah, hello? 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 Okay. So the good thing is that in anemia of inflammation, apart from all these iron parameters, the signs and symptoms of the underlying inflammatory condition will also be there. So you need the history and the diagnosis for that condition. So you can link. You can link. If so, how do you treat? Very simple. Tackle the underlying inflammatory condition. Because if you don't do that, the inflammation is new, and hepcidin will always cause those troubles. WBC will always be manufactured to the disadvantage of RBCs. So please tackle the underlying cause. If it is HIV, manage it well. If it is arthritis, manage it well. If it is cancer, manage it. That is the only way out. In these situations, hemotransfusion is normally not needed. It's normally not, unless maybe the patient stays in the house and by the time maybe he or she presents, the HB is very, very low, something lower than 8. Then fine, that one you may need to give some 2 or 3 pints to push it forward a bit. Then you continue with the treatment. Remember, at that point, hepcidin is in action. So giving iron 2 will not work. And it won't work. There is what? Compromised iron absorption. Compromised iron absorption. So you don't. Okay. Now, should the need be that we give hemotransfusion, let's say the HB is very bad. So this one is applicable to iron deficiency too. So in both situations, if the HB is very low and therefore there is an acute need for hemo or for hemoglobin increase, then you give what? Your hemotransfusion. As always, you start with your grouping and cross-matching. We don't want to have any incompatibilities. So the hematologist will do that. And if it is confirmed and we get compatible blood, then we hemotransfuse. Issues that can happen is if your patient is already congested and you are using whole blood contains a lot of plasma. By giving a lot of whole blood for a patient who is already congested, like CKD patients or liver patient or heart failure patient, whole blood in excess will add onto the existing injection and precipitate the whole issue. In this case, your option will be packed cells, which will have relatively lower amount of fluid aspect. If you don't have packed cells, then the strategy is to administer low dose fusimide, let's say 20 milligram, maximum 40 milligram, to clear some fluid from the patient before you give your whole blood. This is not the only problem that you can get for hemotransfusion. Somebody can still react, regardless of all the grouping and cross-matching that we have done. We have a lot of antigens that we are even yet to discover. So you can still have issues. So in the ICU, we have what we call TRALI, transfusion-associated lung injury. Transfusion-associated lung injury. The lab people will do all their tests and confirm that, yes, this blood is very good for this patient. You give the blood to the patient reacts, mounts an inflammatory response that can even attack the alveoli and destroy the lungs of the patient. Then we are in trouble. We have ARDS called TRALI, transfusion-associated injury. So patients can easily react to hemotransfusion, even though the necessary grouping and cross-matching has been done, they can still get it. If blood stays for longer periods, RBCs will hemolyze, iron is released into the plasma. So in the container housing the blood.
Please.
Hello?
Please, you mentioned furosemide. I didn't get that part. You said give furosemide. Can you explain that?
Furosemide came in because if you are giving blood, whole blood, to certain patients, for example, liver, kidney, heart, who are already having problems of fluid congestion, consider whole blood. It has a lot of plasma. So you giving the blood, you may give multiples, maybe 3 pints, 4 pints, 2 pints. You are only going to add more fluids to the patient, and that will precipitate the congestion. So in that case, the best option is to use another blood product that will give you the RBCs, but with smaller volume so that it doesn't precipitate. If you don't have packed cells, then another option is to give the person furosemide, which is a diuretic, to let the person lose some amount of fluid to make way for the incoming one that will come in with the blood, so that when you introduce your blood, it won't precipitate the congestion. Are you okay?
Yes, please. Please, I have another question. You mentioned earlier that diabetes type 2 can lead to inflammation. I didn't get the explanation.
No, it is an inflammatory condition, not that it can lead to. It is already. Are you okay? Yes.
Please, can you give the explanation once again?
Why? Because you do inflammation with Profatakra, but as part of the pathophysiology of insulin resistance in type 2, you will discuss with him that the abdominal fat is a very bad fat in that it releases cytokines. We call it adipocytokines. These will cause inflammation. It can even cause thrombosis. So you have a lot of TNF alpha being released, you have prothrombotic agent, you have resistant as a resistant agent. All these things are there. So if you are obese, type 2 diabetes, this is an inflammatory condition. Why? Because the abdominal fat causing insulin resistance will not only do that, it will also release inflammatory mediators. Then you have that problem. If you are suffering from type 1 already is an autoimmune distraction, produce antibodies and a lot of cytokines, and you destroy your own insulin or the beta cells. So in diabetes, we are having a problem of inflammation, and that can give you anemia as part of the anemia of inflammation. Are you okay?
Yes, please, I'm okay. Thank you.
All right. Okay. So we are considering potential problems with. Yeah, hello.
So please, can you take me through the transfusion-associated injury once again?
Yes. So that is what we call TRALI. Have you done emergency pharmacy? Hello?
Not yet, sir.
But you do it?
Yes, please.
Which hospital are you?
Tatama General Hospital.
Okay, so I'm sure as part of your discussions with your preceptors, they will take you through TRALI. So TRALI will come in when you are doing ARDS, acute respiratory distress syndrome. So in individuals who will have an inflammatory response, transfusions is inflammatory in nature, and the antibodies can go all the way and attack your alveoli, causing distractions to your primary and secondary cells in there. So the alveoli become congested, destroyed. You have a lot of inflammatory exudates within the lungs. And you see the lungs are supposed to be airtight. They're not supposed to have anything other than air, no fluid, no solid. And because of this inflammatory response coming from the transfusion, you now have inflammatory exudate. And that will impair ventilation and perfusion. In emergency pharmacy, ICU, we call it VQ mismatch. get VQ mismatch that is typical of ALDS, then you are in trouble. So all these are just examples of the reactions that somebody can get from just receiving blood. And that has high mortality or fatality case ratios if you don't get experienced intensivists and emergency care specialists to handle the case. So that's just an example. Others can get some mere reactions, some rashes, and with cortisone, then we continue. Mild ones. But if it happens like laterally, immediately we need to abort and then maybe intubate and manage you. So no problem. Anaphylactic reactions with transfer if you are doing whole blood. Another one could be iron overload, especially when the blood was harvested, it has stayed there for some time. Red cells will begin to rise, releasing their iron content. So your blood will be having a lot of iron. So you get heme transfusion and suffer from iron overload. Once you can even get irritations and then vomit blood. So nausea, vomiting that may come with blood, multi-organ dysfunctions, including your kidneys, your brain, and whatever. So we don't want to see that. So these are possible problems that you can get. Don't forget still the possibility of bloodborne infections. It's not every condition that we screen. Even common malaria, you can get it from transfusion. Yes, they will do a lot of screening, but there is still that potential because they don't screen for all conditions. And therefore, they have their usual protocol. Some 1, 2, 3, 4, 5 conditions, they screen and then they clear it. What if the others are also there? So you can get bloodborne infections as part of the problems with hemotransfusion. So I don't blame the Jehovah's Witness so much if they decide not to take blood. The risk is very serious. But if you want to take it, no problem. You take it, and if you don't get any problem, you survive. If you're a Jehovah's Witness too and you decide not to take it and you survive, fine. If the other one happens and you die, that one too, fine. Now we have patient charter, and that is to ensure the rights of the patient. The moment the patient says no, that's a no. You can't do anything. The only time that you may do something is when the patient is in coma, unconscious. There is no relative there, and therefore, you, the practitioner, you have to decide. So at that point, by the time the Jehovah's Witness wake up, blood transfusion has been given. You may not suffer from any legal issues. At that point, you are free to do it. So don't forget the issues with transfusion. Possible bloodborne infections, possible iron overload, anaphylactic reactions, including both mild and severe forms, TRALI. Then fluid overload. These are all possibilities in hemotransfusion. All right. Now, since we have implicated inflammatory mediators and specifically interleukin-6, yes, we say that interleukin-6 in particular is responsible to a larger extent when we are talking about the release of hepcidin. So can we give drugs that can specifically attack interleukin-6 so that hepcidin will not be released? Is that a possibility? You can take that one as your research in your advanced studies or postgraduate studies. You want to investigate into the possibility of agents that antagonize interleukin-6 in management of anemia of chronic inflammation. That is up to you to consider, and I wish you all the best. Class Captain, any issues before we move to the third microcytic anemia?
No, please.
Okay. So I think my lady has
I have a question.
Yes.
Yes, I need some clarity here. When hepcidin is released, it blocks the release of iron into the blood, which is later picked up by transferrin, right? So my question here is, how will total binding capacity be low if hepcidin is blocked? If hepcidin is blocking iron?
No, hepcidin is rather trying to move iron from the blood to tissues. And how is iron transferred? Via transferring, is that not so? So the iron will have to bind to the iron binding surfaces on transferring, making the binding surfaces not available anymore. And therefore, if you are to put in further iron, there are no binding surfaces to bind on transferring, and therefore total iron binding capacity will be low. Are you okay?
Yes, thank you.
All right. That's Captain. Any further questions? If not, we are moving to the third.
Please, I have a question.
All right.
Please, can you move to the slide before you went here? I want to repair. Okay, so for the indication where you said cancer subjects who cannot be given hemotransfusion and those on platinum-based chemotherapy. So I want to understand why those on platinum-based chemotherapy should be rather given the IV iron plus the EPO instead of transfusion.
Yeah, so we are talking about in situations where the patient may react and therefore we can give. Meanwhile, the platinum base are corporate when it comes to anemia. They are corporate. And therefore, in those individuals, that is when you give EPO. We are rather, thank you for even reminding me. We are rather talking about indications for the introduction of erythropoietin as drugs. So erythropoietin as drugs, normally, cancer chemotherapy, when the patient is on platinum base, they cause a lot of issues with anemia. They cause a lot of anemia issues. And at that point, it may not be advisable to give hemotransfusion, or the patient may react, because we don't want to give iron to patients who are immunocompromised. Remember, we said hemotransfusion can introduce iron overload. It means blood can bring in more iron. You never want to introduce iron to patients who are immunocompromised. Why? Because at that point, should they get any infection, they themselves cannot fight the infection, and you have given the infectious agent enough iron to proliferate with no fighting back from the person's immunity. And therefore, the infection is going to be massive. So in such situations, you are not giving hemotransfusion, and the drugs that you are using to treat the cancer is causing anemia. The cancer itself is also causing anemia. Then we introduce erythropoietin analogs to come in and help. So the erythropoietin, we have different types, the alpha, the beta, theta. One issue that we have with erythropoietin is the possibility of it affecting only the red cell lineage through an autoimmune reaction. We call it the pure red cell aplasia. We discussed it in, I think, our first lecture, pure red cell aplasia. In some individuals, the moment you give them erythropoietin, they can mount an inflammatory response, produce antibodies against the drug, and produce antibodies against red cell production. And therefore, the moment you give the drug again, it won't work. So you are giving the drug, and your target is to expect increased levels of hemoglobin and, for that matter, RBCs. But the patient will not respond. If that happens and it doesn't affect WBC levels and platelet levels, but only RBC levels, we refer to it as pure red cell aplasia. Now, if you are giving erythropoietin, especially in CKD patients, they can cause increased production of RBCs. They can cause polycythemia, excess production. And when this happens, it may increase the viscosity of the blood and contribute to high levels of BP. So excessive BP can happen. So hypertensive crisis can happen when you are giving your patient erythropoietin. Why? Because the patient may produce excess amount of RBCs. For this reason, especially in CKD patients, it is advised that you target between 10 and 12 HB, even though in adults, that may not be the normal range. But to avoid hypertensive crisis, Once you hit between 10 to 12, you need to adjust your dose. If possible, even withdraw. Because if it hits above 12, there's a problem. In some subjects like diabetes, you're allowed to go around 13 because of the glycation that the glucose can do. So those ones, glycated hemoglobin, normally may not be able to function well. And for that matter, you can do up to 13. Aside diabetic patients, please don't target above 12, because if you do that, you can cause crisis. So these are the few problems with giving epoetin: pure red cell aplasia and the possibility of hypertensive crisis, be it emergency or urgency. It depends on whether target organs will be destroyed or not. So these are the two main parts. So the moment...
Please, a little lost. Can you explain again the problems with giving the erythropoietin?
Yeah, so the first one that is pure red cell aplasia. You give these erythropoietin analogs to patients. You can give it per SC or IV. It depends on the brand and the type. Then the patient will mount an inflammatory response, produce antibodies against the drug and against RBCs without affecting platelets nor WBCs. It's only RBCs that are being destroyed. And for that matter, you are also not producing. So the drug is not working, you are not producing RBCs. If you are giving erythropoietin, you expect the opposite. You expect erythropoiesis to occur. And therefore, you expect RBCs to increase. Imagine if the amount that you have, you start erythropoietin and it even begins to go down. Maybe you are at 9. You expect it to increase, and you are now having 8, 7, 6. You check platelets, you check WBCs, they are unaffected. That could be pure red cell aplasia. Antibodies being produced against the drug and against WBCs. So that is a problem. If it happens, you need to abort. Another problem is the possibility of hypertensive crisis if your patient is on erythropoietin. Why? Because if you give it and you have excessive amount, that is polycythemia, making your plasma viscous. Viscosity will increase your heart peripheral resistance, and that will increase your MAP. Your increase P. Depending on whether a target organ will be damaged or not, you can have either of the two, either emergency or urgency, but they are not going above hemoglobin concentration of 12 for normal subjects. Target between 10 and 12, and that will protect you from causing hypertensive crisis. For diabetic subjects, because of the presence of glycation, you can do 1 unit higher than 12, that is 13. And you are not likely to cause a problem. Apart from that, don't do more than 12 for any other patient. If you do that, you can cause hypertensive crisis and cause harm to the patient. So, main problem: hypertensive crisis, pure red cell aplasia, erythropoietin administration. To discuss this again in CKD with Profatakra. So this is just an introduction to it. Please, are you okay?
Yes, please.
All right.
Yes.
All right. So always remember to treat the underlying inflammatory condition in anemia of inflammation. Then if there is a need to maybe hemotransfuse, fine. But be aware of the possibilities of all those complications with hemotransfusion. The third, microcytic anemia, meaning this one too, hemoglobin will be low, your MCV will be low, MCHC will be low on the FBC panel, just like the two that we have discussed: iron deficiency anemia and anemia of inflammation. But what is different in this case? How do we differentiate it from the others? So to be able to appreciate, we are not going to go through this long biochemical pathway. We are just going to hit on the areas that are important to pick. So we are looking at the biochemical synthesis of heme, the production of heme, the aspect that contains iron, hemoglobin, heme plus globulin, iron aspect of hemoglobin. So to begin with, you have glycine binding with succinyl CoA. This cannot happen unless you have an enzyme called alpha aminolevulonic acid synthase. Alpha aminolevulonic acid synthase. This enzyme needs vitamin B6 as a cofactor before it can function. This enzyme needs vitamin B6 as a cofactor before it can function. And if you have enough vitamin B6, you have ALAS in action, well intact. Then glycine can be added to succinyl CoA. Then you have your aminolevulonic acid. Then through several other intermediate steps, you get to the level where protoporphyrin is produced. And protoporphyrin is added to iron. So adding an inorganic ion to organic ion. Here too, we need an enzyme. And the enzyme that will catalyze this addition is called ferrochelatase. Ferrochelatase. So protoporphyrin plus ion, you get heme. And the enzyme responsible for this biochemistry is called ferrochelatase. Interestingly, you can see lead poisoning here. So if you have lead poisoning, lead can chelate or antagonize ferrochelatase. So it means that you are not going to produce heme, because without the enzyme, you cannot combine protoporphyrin and iron to get heme. So lead poisoning can prevent heme synthesis. You can do that. Then upstream here, you can see that lead again is antagonizing the second step. So it means that if you have lead poisoning, both upstream and downstream, it will be affected, and therefore you can't produce heme. If any of these enzymes mentioned, ALAS, ferrochelatase, are defective or absent because of your genetic makeup, you are in trouble. It means that you cannot produce heme, especially if you are looking at ferrochelatase and then the beginning, which is the rate limiting step as well. We don't have ALAS intact. No. Even if you have ALAS and you lack the cofactor, which is pyridoxine, vitamin B6, that one too, you can be in trouble. So in sideroblastic anemia, the whole problem is that we have genetic problems and the ones that are not genetic. And the basic issue is that whether genetic or non-genetic, the person has enough iron, but cannot incorporate the iron into, and for that matter, hemoglobin. That is the problem. At the end of the day, the person will produce red blood cells, still maintaining their central nucleus. Proper red cells don't have nucleus, but hemoglobin. And since you lack the enzymes or the cofactor, or you have been poisoned by something like lead, you are not going to produce hemoglobin, meaning the iron will not be utilized. So the person's RBC still maintains the central nucleus with iron granules surrounding the central nucleus. So on a peripheral blood smear, if you see such RBCs with nucleus being surrounded in a circular manner by iron granules, these RBCs are called sideroblasts. And these are useless RBCs. Eventually, they will be destroyed by the reticuloendothelial system, and the person will get anemia. If this happens, it is termed sideroblastic anemia. Sideroblastic anemia. That is a typical example of microcytic. Why? Because the iron is there, but you don't have the capacity to use it. It's more or less like you don't have it. If you have it, use it and let's see. So if you don't have it, you are not using it. It's just like it is not there, and therefore you can't use it. Hence, a similar picture compared to the two that we have discussed, microcytic, hypochromic in nature. You differentiate it from the others utilizing peripheral blood smear, where you witness. Hello? 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 I did not hear you, please. The one who just... I didn't hear you.
I was saying take the whole process again. I didn't really get it.
From where? Even the biochemistry.
After the lead poisoning.
Yes. So I'm saying that since you have iron, but you can't utilize it, it's more or less like there is no iron. There is no iron. Because if you have it and you can't utilize it, it's almost just like it is not there and therefore you can't use it. Hence, a similar picture to that of iron deficiency anemia and anemia inflammation on the FBC panel. Low MCV, low MCHT, low MCH. As for hemoglobin, it can only be low because you're not even producing. How can you produce hemoglobin? And therefore, to differentiate it from these two, you have to use exclusively sideroblasts. Sideroblast, that is red blood cells still maintaining their central nucleus with iron granules surrounding the central nucleus in a circular manner. Sideroblast will be seen. And if this happens and there is anemia, we call that type of anemia sideroblastic anemia. Remember, there is excess iron in this patient because the iron can't even be utilized. But if you base your argument on the FBC, and let's say you conclude that it is iron deficiency because MCV is low, MCH is low, MCH is low, HB is low, then you conclude, oh, iron deficiency. You start introducing iron. This patient, they do have more than excess iron. They even need iron to be taken from them. And because we did not confirm with further studies, you are introducing more iron, you are causing iron poisoning, and the patient will suffer from that. Please, are we okay? Are we okay? So now, note that sideroblastic anemia can be genetic. That is hereditary form. You inherit it from your family line. In that case, the enzyme, the rate-limiting enzyme, which is ALAS, may be defective or not even in existence. So you can't even start the first process. You are in trouble. Or your family doesn't have anything, but due to your own exposure, you are predisposed. You are born to this world. It wasn't predetermined. Predetermined is when you inherit it from your family line. But this time it is predisposed, where you come into this world and then you have an encounter with certain things, then you face that problem. So that is what we call the acquired forms. So if you are talking about hereditary forms, think the genetic way. Acquired forms, your exposure to certain environmental factors, and you suffer from the condition. Alcohol is very stubborn. It produces acetaldehyde as a metabolite that can cause a lot of problems. So individuals who are chronic alcoholics, you realize that about 30% of chronic alcoholics will suffer from sideroblastic anemia. We are going to look at how alcohol contributes to sideroblastic anemia. So with the hereditary form, the enzyme that catalyzes the first step, that is glycine plus succinyl-CoA, giving you aminolevulonic acid, is not going to happen because the enzyme is defective, so you are in trouble. The acquired forms is either, so the acquired form means that you don't have any issue with hereditary. The enzyme is intact, it's not defective, yet you are having sideroblastic anemia. So in that it could control some drugs, including alcohol, or again, we may be idiots. Why is it that something is happening and not identify the cause? It's because you are an idiot, and therefore idiopathic forms or idiopathic cause. Now, let's look at some of the acquired causes. The acquired cause. So, if maybe you get cancer, of course, it can affect the bone marrow and this problem. Yeah, hello? 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 Is somebody talking? Can I continue, class captain, please? Hello? Class captain, are you there? Is there a question of? All right.
That please was a mistake. You can continue, please.
Okay, all right. So now, you can have an encounter with certain environmental agents, and that affects, say, the enzyme ALAS, or maybe the cofactor will be affected. Remember, both the enzyme and the cofactor, you need them for the first step to occur. Because if the first step doesn't occur, the process will not go through. And therefore, any environmental agent that affects ALAS, or even any of the enzymes and their cofactors within the biochemical pathway of heme synthesis, will definitely lead to sideroblastic anemia. So now, let's look at some possible scenarios. Remember, the cofactor 2 is very important. That is vitamin B6, pyridoxal, or pyridoxine. Now, it is true that being a cofactor, then the enzyme needs B6 to be able to function well. So again, anything that affects the cofactor and or the enzyme itself, trouble. So let's look at alcohol, ethanol. Acetaldehyde as a metabolite of ethanol, it can lower the levels of ALAS, which is the enzyme, and pyridoxal. Pyridoxine is vitamin B6, water-soluble vitamin. Alcohol can have a diuretic effect, and if you are water, you can be cleared. So B6 levels can be reduced. Alcohol can do it. So you see, alcohol is not affecting just one, both the enzyme and its cofactor. That is why a 30% of alcoholics do suffer from sideroblastic anemia. Let's look at our own friend, isoniazid, one of the key, the backbone of TB management, isoniazid. When patient takes isoniazid, it can react with vitamin B6. The product that is formed is easily excreted, very soluble, and therefore can easily. So it means that isoniazid can reduce pyridoxal levels. Reducing the cofactor levels will not allow the ALAS to function properly. And that is how isoniazid, as an environmental agent, may contribute to sideroblastic anemia. You can see high dose chloramphenicol in doses more than 4 milligrams a day. If you take chloramphenicol more than 4 milligrams a day for longer periods, the mechanism of action of chloramphenicol is to inhibit mitochondrial protein synthesis. Chloramphenicol inhibits mitochondrial protein synthesis. Unfortunately, ALAS is a mitochondrial enzyme. Enzymes are proteins. ALAS is a mitochondrial enzyme. So it is manufactured in the mitochondrium, and chloramphenicol inhibits protein synthesis in the mitochondrium. And if it is true that enzymes are protein in nature, then chloramphenicol can negatively affect the protein ALAS, which is formed in the mitochondrium. Unfortunately, chloramphenicol targets mitochondrial protein synthesis. So ALAS will be in reduced levels, and therefore we can get sideroblastic anemia from chloramphenicol. Copper chelators, those who suffer from Wilson's disease, excess copper levels, Wilson's disease, we will give them some drugs that can chelate copper some drugs that can chelate copper to be able to reduce the harmful effects of excessive levels of copper. We need copper to activate ferrochelatase. Remember ferrochelatase, the enzyme that catalyzes the last biochemical stop, protoporphyrin being added to iron, is catalyzed by ferrochelatase. And if this copper chelatase, hello? All right. If you have copper chelatase antagonizing ferrochelatase, it means the last step where we incorporate iron into protoporphyrin to form heme will not occur. You can see iron. We said iron inhibits both upstream and downstream enzymes. Iron can also inhibit ferrochelatase and inhibit aldehydrates, and therefore it will greatly affect the biochemical pathway of heme synthesis. These are examples of agents that can contribute to the acquired form. Yeah, hello?
Hello, sir.
Yeah, hello? Yeah, in Wilson's disease, individuals tend to have excess levels of copper.
Okay.
And therefore, the treatment option is to chelate copper as a metal. We give copper chelatase so that we reduce the levels of copper and manage Wilson's disease. Unfortunately, copper is needed in the biochemical synthetic pathway of heme because we need copper to activate ferrochelatase, this same last enzyme that catalyzes the last step. So if you are chelating copper and you overchelate, you will get reduced levels of copper, and copper will not be available to activate ferrochelatase. So overchelation can lead to what? Sideroblastic anemia. In your attempt to treat Wilson's disease by chelating copper can cause low levels of copper. With low levels of copper, you cannot activate ferrochelatase, and therefore the last step cannot happen because you need an activated ferrochelatase to catalyze that step. This reminds me of iron overload. I forgot to mention how you manage iron overload. Class captain, can you with that? What are the options for iron overload? I think it's on the next slide or something. So iron overload, we give iron chelatase. Iron 2 is a metal just like copper. So we give IV dexferoxamine, or the oral forms D-ferroxyrox or desferriprone. These are iron chelatase that can chelate excess iron, and then we excrete them so that we deal with iron overload. So back to sideroblastic anemias. These exposures, these environmental agents can attack either ALAS, any of the other enzymes, or the cofactor of ALAS, that is vitamin B6, and contribute to sideroblastic anemias. Remember, we have the genetic ones, inherited ones that you inherit from your family line. That one, normally, there's a problem with the enzyme itself. There's a problem with the enzyme itself. In these cases, of course, you get anemia. It could be either mild or severe, depending on the situation. Normally, of course, you see that such patients, even from infancy, will be demonstrating this sideroblastic anemia, and likely there may be some other family members with that condition. So history taking is very important. Peripheral blood smear, key, because you are going to see sideroblasts. Sideroblasts are abnormal, and therefore the cells of the reticuloendothelial system, principally macrophages within the spleen, will have to act. So when these cells get to the spleen, they will be sequestered for destruction. And due to excessive sequestration, the spleen will become enlarged. And therefore, splenomegaly is one other clinical manifestation that happens in sideroblastic anemia. As for the cerebral blast meal, it is key, because that is the only option that will help you to see the sideroblast. As I said, there will be hypochromic microcytic cells. Why? Because it is just like iron deficiency. Though iron is there, but you can't use it. So it's more or less like it's not there. Normally, iron studies is unrevealing. It's not necessary, because we use that one for the differentiation between anemia of chronic disease and iron deficiency anemia. So chelators, stop. Lead, stay away. So that is what you need to do. For the hereditary form, it is an inherited defective enzyme, and therefore you can't do much. So what you can do is that if, let's say, the enzyme is halfway, it's not like zero, but maybe partial defect, then you can only boost the enzyme by providing more of the cofactor. If the enzyme is defective and you don't have enough cofactor, then you are destroying the whole show. So you make sure that you give large doses of the cofactor, so that at least the little effect that the defective enzyme can give us, you are sure that the cofactor is there to help the enzyme. But mind you, remember that excessive levels of pyridoxine 2 can lead to neuropathy. So if you are giving too high doses, you should be careful. Now, as part of the management of the acquired forms, evidence shows that heme alginate can also help increase levels of proper red blood cells and rather decrease the level of sideroblasts. Heme alginate. Iron supplement is in red because there is no room. Don't go there. Remember, these patients do have iron in excess, just that they can't even use it. They don't have the capacity to use it. So if you base your conclusion on the FBC and mistakenly conclude that MCV is low, MCH is low, HB is low, MCH is low, so yes, it is iron deficiency. That's the most popular one. And you have even done peripheral blood tests and all those things. You throw in your iron. Unlucky for you, it is sideroblastic anemia. You have killed the patient. You are only going to cause iron overload. Iron overload. So if in this case the HB is too low, then of course also all the problems discussed and the hemotransfusion still holds. And if you have iron overload, these are examples of iron chelators. The IV form or the parenteral form is called dexferoxamine, and that is the regimen. If you give vitamin C in addition to it, it will boost its effect. Be careful not to give dexferoxamine with CNS agents like prochlorperazine. The patient may lose consciousness. If you don't have the injectable form, you can also use oral iron chelators, desferriprone and D-ferracirox. These are key for MCQs, GPQE MCQs. These questions are very, very common. Injectable iron chelator, desferroxamine, the best. That is first line. That is best, first line. Very, very good, because it can attack both free iron and even iron bound to ferritin. It can chelate. Whether you are bound to ferritin or you are free iron in the serum, you'll be attacked by desferroxamine. It is first line. But if it's not there, then you can try some of the oral forms of iron chelators, desferriprone and D-ferracirox. Any queries? Any queries? So we are done with 3 of them.
Yes, please.
Yes, I'm coming. So we are going to push thalassemias to hemolytic anemias, though it is an example of microcytic anemias, because with that, destruction occurs a lot, apart from the pathophysiology. So we will look at thalassemias when we are dealing with iron deficiencies. You can ask your questions.
Please, in your presentation, you made mention of splenomegaly as a clinical manifestation of sideroblastic anemia in iron parts. Please, can you
Yes.
go over?
So you see, we all want biconcave shaped RBCs. No iron granules, no nucleus. The center should be filled with soluble hemoglobin. Then you, sideroblast, the body soldiers sees you, a membrane, nice one. But